Welcome everybody, my name is Ádám and I would like to present you my 6 months progress. My PhD topic is endometriosis-related pain relief. I'm a 4th year resident doctor in obstetrics and gynecology department. I have a vision: endometriosis-related pain should be a concept of the past with 1 pill a day. And my mission is to find the most effective pain relief therapy for endometriosis. Here you can see my 2 topics. The first is investigating the surgical therapy for endometriosis, and the second one is investigating the medical treatment for endometriosis. Let's start with the first one: comparison of robot-assisted versus conventional laparoscopy for treatment of endometriosis. It's a systematic review and meta-analysis. Has anyone ever seen a lady suffering similar? Who wouldn't want to help her? Of course we do. Indeed, behind this, endometriosis may very often be the cause. Endometriosis carries a high individual and society cost. There's a lot of available therapeutic options, but let's focus on surgical interventions. Nowadays, we can choose between 2 techniques. The first is the gold standard conventional laparoscopy, and the other one is the relatively newer technique, robot-assisted laparoscopy. Of course, we have a third option, but nowadays it's just a rescue option if you have a serious complication in a previously mentioned 2 techniques. And the question rightly arises: why is robot better? Here you can see a list, which is the advantages of the robot-assisted technique. If I would like to assume with one sentence, it helped the patients make the recovery faster. And the more important question: do these advantages come out in practice in the field of endometriosis surgery? That's why our aim is to compare the REL and the CL in the field of endometriosis surgery. Our clinical question: is REL safer and more effective than the CL in the field of endometriosis surgery? Our population patients who underwent surgery for endometriosis, we compare the previously mentioned 2 techniques, and our outcome is the different perioperative outcomes. Our hypothesis sounds like, of course, REL is superior to the CL in the field of endometriosis surgery. And after we finish this procedure, we can improve the care of endometriosis nearby the patient's bedside. Here you can see our systematic search. Our search numbers are very simple search key, and after the end of the procedure we got 13 eligible full text. Here you can see our outcomes, 8 outcomes: intraoperative and postoperative complication, the operating room and operative time, estimated blood loss, number of conversions and rehospitalizations, and stay and length of stay in the hospital. To our surprise, we cannot achieve the result what we were expecting. We can't substantiate the previously mentioned advantages in our investigation. Moreover, we can't find any difference between the previously 2 mentioned techniques, excepting for 2. And surprisingly, in the particular aspect of the result was unexpected, and that's what you can see here. The operative time, which was measured from the skin incision to the wound closure, and it will be a very important information in minutes. And what we can see here, an approximately 30 minutes longer operative time regarding the robot-assisted technique. Then this is not what we were expecting. Our strengths: the operation room time was a novel outcome, and our study period was long. And of course, we have limitations. We have a lot of retrospective studies. We just got 1 RCT, and we can't scale the severity of the endometriosis. And the patient selection was based on the availability of the robotic room. For conclusion, for endometriosis surgery, RAL does not have statistically demonstrable advantages over CL in the terms of perioperative outcomes. Implication for practice: it's very simple. In general practice, CL should be the first choice. Implication for research: we need more further randomized studies. We need to investigate the practical advantages over CL, in which has been poorly studied yet, and the medical economic impact. This manuscript has already published in a D1 journal. Here you can see our graphical abstract. And Now we know how to treat endometriosis surgically, and now we explore how can we help medically. Investigating the most effective medical treatments for endometriosis-related pain. It's a systematic review and a network meta-analysis of randomized control trials. The background is similar. Almost every 10th woman suffering from endometriosis, the symptoms can be very diverse: dysmenorrhea, pelvic pain, dyspareunia, and so on. Let's focus on medical therapies. We can divide it into two groups: hormonal treatments, non-hormonal treatments. We need to choose a 6 months follow-up time because the limitation of the hormonal treatment side effects. Here you can see the investigated drug types. The size of the green bubble represents the importance of the given drug type. Combined oral contraceptive, gonadotropin-releasing hormone antagonist and agonist, progestins, aromatase inhibitors, selective estrogen receptor modulators, NSAIDs, and opioids. Our clinical question: which is the most effective therapeutic options for endometriosis-related pain? Our population, women of fertile ages with endometriosis, we compare the previously mentioned different drug types, and our outcome is endometriosis-associated pelvic pain. And our hypothesis: combined oral contraceptives, because it's most widely used, are superior to the other therapies for endometriosis-related pain. And after the whole procedure, we can improve the care of endometriosis. Here you can see our systematic search, our search numbers, and the 4 big boxes of our search key. At the end of the whole procedure, we got 47 eligible full text. Here you can see our different pain scans, what we used. The most commonly used was the visual analog scale, which is a scale to measure pain from 1 to 0. Everybody know that. And I bring you just an example from our outcomes. Dysmenorrhea after 3 months. What you can see here is our ranking probability figure, and it shows us that GnRH antagonist is the best option, and the placebo is the worst one. We can get numbers, a p-score from, it's not p-value, it's p-score, from 0 to 1, and 1 is it's a theoretical the best option, the best treatment. Okay, here you can see the network figure, the forest plot, and the Sukra curve, which gives us the same information like the ranking probability. For conclusion, in case of dysmenorrhea, we need to choose GnRH agonist supplemented with oral contraceptives. In case of dyspareunia, we need to choose alone oral contraceptives. In case of overall pelvic pain, we need to choose oral contraceptives or progestin combined with aromatase inhibitors. Implication for research and practice. Honestly, dyscasia and dysuria are the leading symptoms in case of deep infiltrating endometriosis, but during our investigation, we couldn't find any data about them. So it's very important we need more information about these. We need further randomized studies and longer observational periods maybe, but I already mentioned 6 months we have a reason why we have the 6 months observation time, but we can try it. We already finished the manuscript, and we sent it yesterday to a Q1 journal. We got 2 rejections from D1 journals, well, maybe now. So that was me for today. Quid pro quo, something for something. Thank you for attention.
István Madár, gynecology. So there is some skepticism surrounding the robotic-assisted operations. However, don't you think that in the background may stay that the operators have also a learning curve, and these robotic operations are for not so a long time in the daily practice, and so you know that even the laparoscopy was surrounded with skepticism when it was pioneered in the first years, but right now, so nowadays, it is, especially in case of endometriosis, it's rather a sin if you do laparotomy instead of laparoscopy. So don't you think that there is sort of a learning curve issue here with the robotic-assisted operations?
Thank you for a question. You have right, and I will give you two answers. The first is about the learning curves. In the literature, there's no, I couldn't find any information about this for specific data about endometriosis, but in general gynecology, hysterectomy is a well-described intervention. And in case of hysterectomy, a learning curve in case of conventional technique about 70 something and operation, and in case of robot-assisted technique is just 23 or 4. I can't remember the exact number. So you have right. There's a big difference between the learning curves of it. And another answer is regarding what was your other part of the question.
Well, basically the skepticism surrounding it.
And it's almost the same question. In the past, people say, oh, the conventional laparoscopy or laparoscopy, it's a very expensive technique. We need a lot of things to do that. But in case of laparotomy, almost we don't need to buy anything. It's just a scalp or that's it. And nowadays it's almost the same question. It's so expensive, the robot-assisted technique, and we can't demonstrate any statistically advantages over CL. So you are right. It's almost the same question.
Thank you very much, Ádám. I really loved your vision and your mission, and I think hopefully we're going to get there. And I think if we have more people like you, we will get there. So I have a few questions, just specifically on the first study. The first and the second study had different endpoints you looked at. In the first one, you looked at, complications.
Yes.
Why didn't you look at efficacy? Was the data not reported?
Efficacy, like quality of life measurements or what?
As you had in the second one, some pain relief or quality of life or some...
We can't find any data regarding this. Yeah. The operator doesn't measure this, but it will be, in my opinion, the most important in front of you, the patients. Who cares this operation lasts 3 hours or just 1 hour? I know that there will be the complication rate will be higher if the operation time will be higher, but the patients don't know that. They just feel that this pains more here or less here, but I can't find any data.
And then, let me ask you, you had one prospective study, I think, in the first one, right? Randomized conventional laparoscopy versus robotic, you said.
More prospective, but only one RCT.
One RCT.
And the others are retrospective.
And that RCT was powered for complications, or what was it powered for? What was it looking as a primary endpoint?
So what was the endpoint?
Of that RCT?
It's different from...
I wonder, when we do this meta-analysis, we often do, and we have a lot of retrospective studies or prospective uncontrolled trials that may totally contradict the one RCT you may have. Was that the case here, or was it just the same?
Just the same.
Okay.
And I write it in the article because the RCT, if the RCT shows us absolutely different results, that would be very suspicious, but not.
Okay. And then your conclusion, I looked at it and I said, you just showed no difference, right? None of the studies was powered for non-inferiority, which is a specific design you have to do. You showed the difference, but the conclusion is CL should be a standard of choice. I would say you care less which one it is if there's no difference, except a little bit longer duration of 30 minutes, right? I understand the cost and the access to the thing will drive, but you didn't show us any cost analysis.
We're looking for that, because that's a really exciting part of the robot-assisted and conventional laparoscopy question, but we couldn't find any data.
Because I think you need to frame your question differently. You said, does robotic improve your complication rate? And then you reject, that hypothesis, and you accept your null hypothesis. So then you can say CL should stay the standard of care.
Yeah,
the way you frame the question.
Yeah, you are right. But should I reframe or
No, I think the conclusions were correct if you would have framed your question differently.
reframe?
But it's a semantic question. I mean, the conclusion is the same, and people will use it the same. The second one, I was wondering, and obviously I'm not an endometriosis, I'm not a gynecologist. I just help my colleagues sometimes during surgery. But is there anything on antagonists being used in this setting? Because you would think this could be also, you have agonists, you showed combined agonists, which is sort of the standard, but nothing with antagonists that you find in the literature, like a LH-RH antagonist.
If your question is, do we use it in the everyday practice?
Or
No?
did you in your research, did you find anything? Because I didn't see any of the antagonists, but maybe there's no research on this, like relugolix, for example.
There's a lot of
right,
studies which
okay.
investigated GnRH antagonists.
Okay.
It's a well-studied part.
Okay.
Your question based on what I show you.
Yeah,
that one.
yeah.
But it's just one outcome, and not every outcome we have data every drug type, because that was not reported after 3 months regarding pelvic pain or dyspareunia. But in other outcome, I can show you that, but not now. But we have informations and data about GnRH antagonist.
And then let me ask you the last question. I think endometriosis is a very complex disease, right? I mean, it's such a complex disease, the symptoms, how the people perceive it, and so on. So the question for me, if you had a multidisciplinary board, right? You ideally have a multidisciplinary board, or at least gynecologists and urologists. It's a gynecological disease, I would say, but our specialties are such that you're well versed in internal medicine and surgical care, right? Specifically endocrine care and so on. So is it possible for you to look if surgery is superior to medical therapy and identify through some form of subgroup analysis, forest plots, which one would be better? Has anybody looked at it? Because it's, I don't think you can do a study like this. You cannot randomize to that, but can you, through network meta-analysis, by find a solution to that or answer that?
Maybe you start your question with the answer, in my opinion, because this question is so complex. This is so complex, and there's so many big differences between the phenomena. So if you ask me, how can I treat a big cyst, a 20 centimeter cyst, better with surgically or with medications? The answer will be easy. But if I saw generally endometriosis, I can't tell you just one sentence, just one quick answer, because if you have just a small plaque on the peritoneum, maybe you can handle it with just medications. So heterogeneous the disease, the entity. So maybe it will be too complex to.
And let me, out of curiosity, one last question. The diagnosis of the true endometriosis is the same across the studies? Is it like transvaginal ultrasound? Is it based symptoms that lead to some form of imaging, or what is it?
In case of the first study, of course, every situation made operation, and of course, in the second study, it was very difficult because some authors just say it's enough for me to make a regional scale at the baseline, and if you have the higher pain above our cutoff, that's endometriosis, or could be endometriosis, while others use ultrasound-based diagnosis and laparoscopically confirmed endometriosis and patient-reported. So it was very diverse.
So some of them could have been IC, some of could have been urethral diverticulum or something weird that may not have, in older studies, not included.
Yeah.
Then there's because your inclusion criteria, if it's so heterogeneous, then your therapeutic arms, may give you that's the problem across all the all the fields. I'm not a gynecologist. I just want to say maybe I've said some stupidities, but thank you.
Thank you.
It was fantastic.
Okay. Tamás Bitó from Department of OBGYN, Szeged. Well, congratulations for your nice work, and particularly for your first authorship in a highly ranked journal. And let me start with a little bit inconvenient question. So there was the incidence of endometriosis was 10 to 15% on your slides, but in your publication is 6 to 10%.
10%.
So what is the true right now?
One of this is what you can find in the literature, and it doesn't matter. It's matter where you looking for is in the worldwide numbers, worldwide data, or just the regions, because and another is an estimation. Because the diagnosis is, as we already mentioned, it's very heterogeneous. So in some countries, it could be last for 7 to 8 years, while other countries is just 1 or 2 years. So that's why we can just, in some cases, we just estimate the prevalence of the endometriosis, and in some cases they in some article reported 6 to 11%, but our opinion, or my opinion, or what we can see in the everyday practice, it's more frequent.
Yes, okay, but somehow it should be
Noticed.
from the literature, which was on the higher incidence on your slide. So I wonder whether RIL is available at your department or not.
Yes, and I help to my tutor, so we do in the everyday practice the robot-assisted technique, so I can feel the advantages of it and disadvantages of it in the everyday practice.
And what was your basic hypothesis? I mean, whether the robotic-assisted laparoscopy is superior compared to the conventional laparoscopy, or the opposite?
It will be depends on the cases of the patient's special backgrounds, in the future pregnancy plans, and we need to assume this. I tell you just a quick story. 2 weeks ago was a conference regarding robot-assisted laparoscopy, and one of the leading person in endometriosis surgery, Horace Roman, started his presentation like this. Welcome everybody, I'm Horace Roman and I'm a robotic surgeon, and this person spent their life 20 or maybe more years with the conventional laparoscopy technique, and he said about themselves, or I'm a robotic surgeon. So I think it's a very important sentence, and it shows us the future.
Well, is it depends from the patients or the stage of the disease? I mean, in case of deep infiltrative endometriosis, which is the more beneficial?
More if the case is more severe, and the endometriosis is more severe. If you ask a surgeon, this technique, the robot-assisted technique, will be a better technique because of more comfortable. The operator can sit in a very comfortable position. The magnitude of the technique is 15 times higher. So, and etc. And more precise movement can we do, and it's a more precise movement with our wrists and hands. So if you ask somebody who already practicing with this new technique, he will mention you that's the better technique.
Thank you very much, and congratulations once again.
Thank you.
So have a question, please. Can we go back for the first study, please?
Maybe this slide.
Yes, so you mentioned in the introduction that your outcomes are also the complications, but this is the only outcome you present, right? If I didn't miss anything.
Only what?
Only this outcome is what you presented.
Yeah, here, because all the others are boring, or how can I say?
That's what I wanted to ask. You mentioned complications. Okay, but what would you think clinically is an important complication that would be decisive in your choice of method?
But it's not a complication, the operative time.
No, but you mentioned complications also as an interesting outcome in your design, in the research plan, in the first slide. If you
But there's no difference between the complication rates. But this is not your question.
I understand.
Okay.
But that was not my question. What would you consider?
I can't understand what you want to...
so can we go back one more slide, please? Here you mentioned intraoperative complication, postoperative complication.
Yes.
So you have here lots of outcomes. Which one would you consider? Because I don't see here like a main outcome. So clinically, which one would be the most important?
The most important?
So let's say in a different way. If you would design an RCT yourself, which one would you choose? Because this is, I mean, there are lots of things, but I can't optimize for everything.
Sorry,
I want the number one primary outcome.
Intraoperative complications. Because
intraoperative complications.
It will be effect on the other outcomes.
And do you have some specific intraoperative complication or just intraoperative complications in general? I mean, I'm not an operator, but I guess it does matter what complication. It's like a big umbrella term.
We can make...
so,
not general. We need to make specific, well-designed, what we call complication. Because in the practice, at this time, we do a registry. And I saw that this is a big problem to how to describe a complication. So we can't speak about generally. We need to well define what we call intraoperative bleeding. It means we rupture the bladder or et cetera, et cetera. So we need to examine every possible intraoperative complication.
Okay, but as a clinician, that's what you find the most important if you would design yourself an RCT. And you did investigate it in your meta-analysis, right? But you did not find it
different.
It wasn't. There was no difference.
No difference.
Okay, but it would be still nice to see if that's like the most important. Can we just go to the next one? And here I see that the operative time, 200, so like in the hundreds, maybe in the 200s. What do you think of the clinical importance of the mean difference of 28?
28, yeah, it's approximately 30 minutes. You need to, as I mentioned, it was measured from the skin incision to the wound closure, and it included the docking time. So the robot we should docking the robot to the patients.
Okay.
And in the literature, we can get a number 18 minutes, the average docking time.
So the docking I'm not familiar, but the docking happens after the first incision.
After that. So it's include the docking time. That's why I mentioned it's very important to... but it's not covered.
Approximately, what is the duration of this docking time?
80 minutes.
80
minutes. But in the practice, in our everyday practice, we measure also these numbers. Our average docking time is about 10 minutes. So it's a little bit, I think it's...
But how would you appreciate this 28 minutes difference with the scope of the docking time as well? Is it a long time for an operator? Does it matter?
I tell you a number which will show you is it or not. If every additional 60 minutes, in case of operation time, 60 minutes, the implication rate will be duplicated. So, but we can't see in the intraoperative complication because there's no difference. But in general, in case of hysterectomy, in case of hysterectomy, you can see these numbers. Additional 60 minutes, the complication rate will duplicate.
Okay, I think that's an answer. So it does matter. 30 minutes.
Yeah.
Okay, and for the second project, what were finally the arms that you included? So you mentioned many different possible drug families that you'd have.
Yeah.
And then in your actual investigation, actual meta-analysis, you finally analyzed only 4 of them.
No, it was, we combined dysmenorrhea, dyspareunia, pelvic pain, and combined with after 3
those
and
are
6
the outcomes.
Months. Yeah, those are outcomes.
I mean the arms, only 4 arms.
Not
Here
4
I
months.
see
No.
1, 2, 3, 4.
Because in case of dysmenorrhea after 3 months, we can just investigate
Here
4 drug
it was
types.
available. Okay.
But in other case,
I have to interrupt
Yeah.
you.
Okay.
because we have to move on.
Okay, thank you.
There will be a lecture, so thank you very much. Thank you.
thank you.